And sickle cell is very complex. It varies from person to person. Our genes are different, so our environment can influence a crisis and how sickle cell exhibits in each of us. When they said that, I'm like, what do you mean you only look for 4 viruses? After all, like, you have all these systems. But that's the thing, because that's a part of the risk. So why this matters, and sickle cell is very complex. It varies from person to person. Our genes are different, so our environment can influence a crisis and how sickle cell exhibits in each of us. If we get sick, if we are losing oxygen, all of those things matter. So our comorbidities matter in sickle cell. Now, what we think blood transfusion does is that it carries malleable red blood cells with oxygen, carrying capacity and delivery capacity. And so we were told they replace damaged red blood cells with healthy red blood cells. What we're actually getting in a transfusion is red blood cells with depleted energy, red blood cells with reduced antioxidant capacity, that are less able to release oxygen. They have free hemoglobin with oxidated byproducts, altered membranes, apoptosis markers, accumulated metabolic waste. And so what that means, the second blood leaves a warm body and is stored, it begins to break down, because our blood naturally in our bodies can, hold on to oxygen. It has a source of that oxygen. And once it's been stored, it's losing its shape, it's losing its capacity to hold on to the oxygen that it carries. When they said that, I'm like, what do you mean you only look for 4 viruses? After all, like, you have all these systems. But that's the thing, because, that's a part of the risk. So why this matters, especially in sickle cell, we know in sickle cell disease, oxidative stress is already elevated. Our nitric oxide is already reduced. Inflammation is already present. Our endothelium is already vulnerable. So when we're adding to our fight, we're adding oxidative stress stored that increases the burden, that impairs microcirculation, that reduces effective oxygen delivery, and it contributes to complications in some patients. And so we, as the patient, we have to understand what we're receiving. So we have to ask ourselves, is this safe? Blood transfusions have been a standard protocol for sickle cell, and we really have been taught not to really ask any questions. We hear this is going to make you feel better right after. Like, we hear, the reassuring words. And so, despite the increased awareness of transfusion-related complications, it'll still remain the first line of defense in treating anemia. And we have to keep asking why. Why should we even ask for bloodless medicine or patient blood management? For us, this is important because at least the approach is patient-centered. It's evidence-based. It's collaborative. So we can feel seen as a person. We're not just presented a blood product as if we're just consumers. And we have to remember, blood banks are a big business. So the approach needs to shift from reaction to prevention and early intervention. So again, we have to change our mindset, our thinking, and our approach in treating our sickle cell. And then when we compare the two, which is safer, when blood is stored, the red cells age, they lose some of their energy and flexibility. They can still help carry oxygen, but they're not as strong as freshly made cells. And so that's important for us to understand, especially in sickle cell care. Optimizing our own blood will always be the safer choice. Restraint matters because there are real and serious risks involved. We've heard of and we've seen these terminologies used, the transfusion-related acute lung injury, where we have a sudden lung reaction after transfusion that makes breathing hard. Doctors are usually taught to look for this within the first 6 hours of transfusion, but the injury can occur past that as well. Then there's transfusion-associated circulatory overload, where there's too much fluid from transfusion that stresses out the heart and the lungs. This can be very life-threatening, and they usually mislabel it as just regular heart failure, but it's actually coming from this complication. Then we are familiar with the aluminization, where the body develops antibodies against transfused blood, making future transfusions harder and even organ transplant eligibility harder. And this one was news to me, but then when you think about blood as a liquid organ, blood transfusions equal organ transplant. So if our body begins to reject the organ transplant of the blood transfusion we received, we also could possibly reject any future organ that our body may need. So kidneys, liver, lung, heart, whatever it is that can come up later, the antibodies that form in our system could actually make us ineligible for life-saving organ donations when we may need it. So that's the other reason why we really have to know the risk. Then there's immunomodulation, where transfusion changes or weakens the immune system. Morbidity and mortality, where there's serious illness or death risk. So we definitely have to treat blood transfusions like a medication that has potentially deadly side effects. So we don't want to be so cavalier. And that's why there's an urgent need for bloodless medicine now with sickle cell disease. We can't wait. Bloodless medicine has proven to be effective in treating several complex blood disorders and extreme blood loss. So why not sickle cell? But I'll admit we do need more research. We need more skilled implementation. But I personally, since I have been treating my sickle cell with bloodless medicine for over 40 years, I am proof that it's possible. And I'm not the only one. I know people who've had more severe forms of sickle cell, and they were able to treat their sickle cell successfully with bloodless medicine, and they were able to live long lives. So again, it's possible, but yes, we definitely need more research, more information, more skilled doctors who are informed to know how to be able to do this all over the world. And this is a very big distinction. Bloodless medicine does not mean do nothing. Blood transfusion avoidance was interpreted as a wait and see, which only increased the risk of complications. Because we already know if you do nothing for anemia, do nothing to help the patient, they're only going to get worse. They're still in conflict. Their body is still under duress. So bloodless medicine is a multidisciplinary, patient-focused, preventative approach, reducing the need for transfusion.